speaking on from a very common disorder. We will now move to a not so common or a rare disorder. Excuse me for a moment. So we'll be talking about Mooren's ulcer. This is something which is first and foremost a diagnosis of exclusion. It's very, very uncommon, so it should not be the primary diagnosis. However, it is equally important to understand that it should be there in the back of the mind of every corneal surgeon whenever we see a peripheral ulcerative keratitis. So basic diagnosis would always be peripheral ulcerative keratitis, and only if we are able to exclude most other things, then should the label of Mooren's ulcer be utilized. So how do we approach these patients who present to us? The approach essentially, as I mentioned, should be that the primary aim or the primary diagnosis would be to see if the peripheral ulcerative keratitis fits into the picture. And for this, we have to always look into doing an aggressive systemic evaluation. It would never be, I would be failing if I did not emphasize that aggressive systemic evaluation in every patient of peripheral ulcerative keratitis is very, very important. It can make the difference between life and death, literally in some cases. So if there is no finding on an aggressive systemic evaluation and the adjacent sclera is not involved, then the patient can be labeled as Mooren's ulcer. So other than PUK, what are we looking at? It is important in various situations for infectious keratitis as a possibility. Now, infectious keratitis would have certain presenting features which are beyond the discussion of this particular talk. But infectious keratitis should always be kept in mind if there are atypical presentations which we see in these cases. We'll come to the typical presentation of a Mooren's ulcer in a minute. Other than that, it is very important to look for collagen vascular disorders, primarily rheumatoid arthritis, polyarthritis nodosa, Wagner's scleromatosis, and various other collagen vascular disorders. In polyarthritis nodosa, it can be the difference because these kind of patients can have very severe systemic presentations. And importantly, these corneas can perforate within 24 to 36 hours. So that is very, very important to understand. And that's the reason why we mentioned that a aggressive systemic evaluation in all these patients is mandatory. It is believed that Mooren's ulcer is autoimmune in origin and has both cell-mediated and humoral arms which are involved. However, this is not really very well understood. It is also believed to be a localized autoimmune reaction to the corneal tissue. So antibodies being produced against the tissue is the belief. However, there are other concepts which have been brought forward, like in some associations with trauma have been mentioned, local infections like herpes simplex, or in systemic diseases like helminthiasis and hepatitis C, some association has been shown, but whether association means a causative inference is a matter which is open, but it is unlikely to be the case is what most of us would feel. So characteristically, it is an ulcer which progresses slowly. Now, this is a question, slowly means what? Because it depends on at what stage the patient appears to you in the outpatients. So a slowly progressing ulcer, which is circumferentially moving and deeper towards the center of the cornea. The key which we feel in Mooren's is important is to see the overhanging lip of the ulcer. In fact, it would be interesting that if you try to use an instrument and go in and see how far you can go in before you can meet any resistance in the tissue, you'll be surprised at the extent of damage that this particular ulcer can cause, even though you feel that the tissue is quite okay to look at clinically. These patients can do well if treated appropriately, and that's what we come to next. So, as we mentioned, systemic workup for collagen vascular diseases is mandatory in all patients. Now, this is something where there are two ways of looking at it. If we work in a large institution and we have the backup, it can be done in-house. Alternatively, for people who are in private practice or in smaller setups, it might be useful to take the support from an internist or a rheumatologist to do an elaborate vascular workup. Local evaluation, as I mentioned, overhanging edges is a very classic presentation, and that is almost pathognomonic of a Mooren's ulcer. Now, the key here is to understand what would be the scenario depending on whether the presentation is unilateral or bilateral, and or what is the given age of a patient. What has been seen over the years is that a unilateral version is usually benign, less aggressively spreading, and can be managed with topical medications in a large number of patients. Bilateral disease, or what is also known as atypical, or in some parts of the literature it is mentioned as malignant Mooren's ulcer. It's a very, very aggressive disease, rapidly spreading, and it can also lead to loss of sight because of corneal melting and perforations if not adequately addressed. So how do we manage these patients? There is the medical line of management, and there would be some surgical adjuncts also, though surgical therapy is an adjunct to systemic or topical therapy is what I believe. Essentially, intense topical steroids. Now, this is something which is important because many a times there is a delay in initiating topical steroids because of the inability to differentiate whether it is an infectious keratitis or otherwise. So that is an important call which needs to be taken. Intense topical steroids in some patients, if there is a unilateral presentation, intravenous methylprednisolone might be used to set up the system or immunomodulate the patient. Along with this, we have found it useful to do conjunctival resection, do a superficial keratectomy so that you can scrape off all the necrotized or dead tissue. Once that is done, a thin layer of cyanoacrylate adhesive applied extending beyond the edges of the ulcer. Now, this is very critical because what we have seen is that if we leave some part of the area unattended, then that can become another leading edge and can continue the progression of the disease. So cyanoacrylate adhesive is important to be spread, go beyond the edges of the ulcer. On top of this, with a bandage contact lens. And these patients then need a very close follow-up because with the amount of cyanoacrylate adhesive and the inflammation, it becomes difficult to differentiate between pure inflammatory reaction and the infections, if any secondary infection creeps in. In cases of bilateral Mooren's ulcer, all of the above, in addition, systemic immunosuppression becomes very, very important because without systemic immunosuppression, most of the bilateral or the aggressive Mooren's ulcers are not going to do well. This is something which is very, very crucial to understand, that being ophthalmologists, many a time we feel that topical medications should do the trick. It does not work in cases of bilateral Mooren's ulcer. Even in a case of unilateral Mooren's ulcer, what I have seen is that if it is showing any kind of a recurrence, then it is important to bring in systemic immunosuppression because it's evident that the primary treatment has not succeeded in arresting the disease completely. The take-home message from this for all of our attendees are that all of these patients, to my mind, require the support of an internist or a rheumatologist because the extent of assessment required for collagen vascular diseases as coexisting problems is something which is very important. And as I mentioned, recurrent unilateral or presenting bilateral diseases definitely need both a workup as well as systemic immunosuppression. In both the cases, the role of a rheumatologist or a very good internist cannot be overemphasized. Thank you for attention.